Howdy, y'all. I'm Laura Womack, and the disease that I chose for the disease report is rubella. Its infectious agent is rubella virus from the family Togaviridae. Some common names for it are German measles or the 3-day measles. This is due to the distinct similarity of the symptoms of these two diseases, despite the fact that they're caused by different infectious agents. It's from the family Togaviridae, of the genus Rubevirus and species Rubella virus. Rubella attracted very little attention until 1942, when Norman Gregg noticed that first trimester maternal rubella caused serious birth defects. In children, illness from rubella infection is pretty mild, so people weren't generally very concerned about rubella prior to this realization. From 1964 to 1965, before the development of a vaccine against the disease, a rubella epidemic swept the United States. During that short 2-year period, there were 12.5 million cases of rubella, and over 20,000 children were born with congenital rubella syndrome, which I'll talk about later in the presentation. As a result, almost 15,000 babies died as a direct result of maternal infection from rubella, either because they were stillborn or did not complete term for the pregnancy. The first rubella vaccine was licensed in 1969 by prolific vaccine researcher Maurice Hillman. In 1971, Hillman's rubella vaccine was used in the combination measles, mumps, and rubella, or the MMR vaccine. The MMR combination shot replaced the original rubella vaccine and is still used today. Then in 1979, an improved live rubella vaccine superseded Hillman's in the United States. It was developed by Stanley A. Plotkin, MD. The RA27/3 vaccine had been used in Europe for years prior and offered superior protection against the disease that was ideal. Because of the successful vaccination programs implemented in the United States as early as the 1980s, rubella has been eliminated from the United States since 2004. However, rubella is still relatively common in other countries across the world. The rubella virus structure is an enveloped, positive-stranded RNA virus that is generally spherical with spiky hemagglutinin-containing surface projections that allow the virus to interact with cell surface receptors on the cells of the immune system and respiratory tract. The virus multiplies in the cells of the respiratory tract and immune system because it mostly attacks epithelial cells and the cells of the immune system. Replication in the organs and cells of the immune system allow the disease to spread throughout the body quickly, so it makes sense that these are the cells that the virus would target in order to be most effective. Approximately 7 days after infection, the virus can be detected in the blood and respiratory secretions, at which point the patient is considered contagious. Humans are the only known reservoir for the rubella virus. A person with rubella may spread the disease to others up to 1 week before the rash appears and remain contagious up to 7 days after it's gone. Postnatal transmission occurs via direct or droplet contact when the infected person coughs or sneezes. Prenatal transmission occurs through the placenta and is incredibly dangerous. This is because of congenital rubella syndrome, which is caused by maternal rubella infection during the first trimester of pregnancy. Pregnant women who contract rubella are at risk for miscarriage or stillbirth, and developing babies during this time period are at risk for severe birth defects. There's roughly a 40 to 60% chance of them developing multiple rubella-associated defects, birth defects that are potentially caused by CRS can include deafness, cataracts, heart defects, liver and spleen damage, and skin rash at birth. Skin rash at birth is exemplified by the baby in the upper picture, who displays the distinctive blueberry-like pattern of rashes that are seen on newborns that have congenital rubella syndrome. And the cataracts are clearly visible in the infant in the lower picture. Rubella infection usually results in mild illness, with low-grade fever, sore throat, and a rash that starts on the face and spreads to the rest of the body. Some other symptoms may include a headache, pink eye, and general discomfort before the rash appears. However, roughly 25 to 50% of people infected with rubella will not experience any symptoms, because the disease can be and is highly contagious while mild. This is dangerous, especially when people who are infected but don't know it are around pregnant women. Other symptoms that occur 1 to 5 days before the typical rash appears are a low-grade fever, headache, mild pink eye, cough, general discomfort, swollen or enlarged lymph nodes, and a runny nose. Neutralizing and hemagglutinin inhibiting antibodies will appear shortly after the onset of the rash and reach their maximum levels in 1 to 4 weeks. Specific antibodies will persist after the infection for the rest of a patient's life. Cell-mediated immunity also develops and can be detected for years following infection as well. Reported rubella incidence increased from 35.5 to 71.3 cases per million among reporting countries during 2000 to 2008, decreased to 2.1 in 2017, and then increased to 18.4 in 2019 as a result of rubella outbreaks in China and Japan. In regards to the incidence and prevalence in the United States, less than 10 people in the U.S. are reported as having rubella each year, and since 2012, all rubella cases have had evidence that they were infected when they were living or traveling outside of the United States. Here are 2 images. The first is reported rubella incidence around the globe in 2000, with this dark blue surrounding the United States and North America being the ideal low, and white standing for unreported data. In the second graph is the rubella incidence for 2012. As you can see, the ideal low has increased across the globe, and the number of countries reporting the rubella incidence has risen as well. In regards to the diagnosis and treatment of rubella, let's start with the diagnosis. The occurrence of the typical rash and lymphadenopathy that generally indicate rubella is usually enough to go off of for most doctors making a diagnosis. This is because the general treatment for the measles, mumps, and rubella in children and adults that have contracted the disease remains largely the same, with the exception of women who may be or are confirmed to be pregnant. Laboratory diagnosis of rubella is typically made based off of the presence of specific IgM antibodies that the immune system produces in response to the rubella virus infection. Because virus isolation procedures are costly and require a relatively sophisticated virologic laboratory, they are seldom used except for the diagnosis of congenital rubella. This is because congenital rubella is significantly more dangerous than general rubella is. In terms of treatment, there aren't really any specific measures that are available for the treatment of rubella. This is because most symptoms can be managed with bed rest and medicines for fever, such as acetaminophen, which are easily accessible over the counter at most pharmacies and grocery stores. There are two steps towards prevention, both of which are the MMR vaccine. First step is the first dose of the MMR vaccine that in the United States children get, and across the world children are supposed to get, as long as they have access to, at around 12 to 15 months. The second dose children are supposed to get at around 5 to 6 years old. This two-step, two-dose program for the vaccination ensures that any child that might have not successfully developed an immunity from the first dose of the MMR vaccine that they received has the opportunity to develop that immunity from a booster dose later down on the road. However, one dose of the MMR vaccine is generally about 97% effective at preventing rubella by creating that lasting immunity in a child. Vaccine-induced infection is usually asymptomatic in children and is generally associated more frequently with rubella-like symptoms in adults. I mention this solely because I thought that was funny. As a child, when I got my first MMR vaccine dose, almost immediately I developed rubella-like symptoms, but several people I know who did not get their MMR vaccines until they were young adults did not develop any symptoms and were asymptomatic. So I guess that just goes to show that in regards to medical information, we have to keep our eyes open because there are always outliers. In regards to the future outlook for the world in regards to rubella, in 2019, that says CDC, but the World Health Organization aimed to achieve measles and rubella elimination in at least 5 World Health Organization regions by the end of 2019. The end of 2020. Forgive me. Based on the 2018 Global Vaccine Action Plan Assessment Report by the World Health Organization's Strategic Advisory Group of Experts on Immunization, rubella control is lagging. 2 regions, the African and Eastern Mediterranean regions, that had yet to set rubella elimination or control targets to date. This is largely because these are the 2 regions of the World Health Organization that arguably have the least access to vaccines and resources. That having been said, here are the resources I used to compile this presentation, and I look forward to hearing all of your questions and lecture. Have a good day.